Hi, everybody. I'm Pat McCarthy. I'm Executive Director of the Bloom Cardiovascular Institute here at Northwestern Medicine in Chicago. I'm a cardiac surgeon, and I want to talk to you today about a topic that I think is really important for cardiologists and internists that have patients that are about to undergo cardiac surgery, and they have a history of atrial fibrillation. There's a lot of new information, there's new guidelines, there's new approaches for this. And there's a lot of good that your cardiac surgeons can do for the patient at the same time that they're there to do a mitral valve operation or a bypass or aortic valve or whatever the heart operation is that they're going to do. Well, first of all, just a few months ago, these new guidelines were published, and I won't go through all of this, but up here it's saying that if the surgeon is there to do a mitral valve or an aortic valve coronary bypass, whatever it is now a class 1 guideline recommendation to do concomitant ablation for atrial fibrillation, level of evidence A for the mitral valve and B for the coronary bypass and aortic valve. And also we changed from the 2017 guidelines to the more recent is now level of evidence A, that you should close the left atrial appendage at the same time. And I'm going to talk to you about the background information that led to these important changes. First of all, if a patient has atrial fib and they're going to cardiac surgery, for a long time we've talked about closing the left atrial appendage and that hopefully it would decrease strokes, but now we really have great evidence. This is a very large database study that was published in JAMA in 2018, showing a reduction in stroke over time and also an improvement in mortality for patients that had left atrial appendage occlusion. And then this was published in 2021 in the New England Journal of Medicine. It's called the LAUS-3 trial. And this is the largest cardiac surgery trial ever performed with approximately 5,000 patients. And what they showed is with an average duration of follow-up of 3.8 years, there was a 33% relative reduction in stroke. So it had a huge impact on patients. If you're sending a patient for cardiac surgery with atrial fib, you really need to be thinking about closing the left atrial appendage. There's a few reasons that you wouldn't, such as a reoperation, but not very many. Most often that should be closed. We all know, and it has been easy to prove for over the last 20 years, these studies go back 2 decades ago, many of them, but if you treat the patient with ablation, you can also reduce the atrial fib. So here's the control group, untreated. Most of these patients with long-standing persistent would not go out of atrial fib if you left it alone untreated. And most of them, if you treat it, will go back to sinus rhythm at 12 months. And so with really small numbers of patients, they were able to demonstrate that you can make the EKG look better and that you're going to get rid of atrial fib in a lot of these patients. But the newer data is the more important, which is not just to make the EKG look better, but there's clinical benefits. There's now multiple papers coming out. This is just the more recent US studies showing that if you treat atrial fib in this group of patients, their late survival is going to be better. So in every one of the slides, the red line appropriately is the untreated patients with atrial fibrillation. So for whatever reason, the surgeons decided not to, it was not fully accepted many years ago to do this. And then the lines above them are showing the survival for patients that have the atrial fib treated in matched series and all. The randomized trials were too short with 1 year duration and too small to actually show a difference in survival. So these are large database multi-center studies. And then this one is from the STS, the big group of Society of Thoracic Surgeons with about 80,000 patients undergoing coronary bypass. So adding surgical ablation improves the late survival for these patients. Do you need to do both? It helps. So this is, again, this is a atrial fib study coming from the STS, and what they're looking for, again, the group with no AF treatment on the bottom here, their survival was not as good. It was better if they had their left atrial appendage closed, but it was best if you closed the left atrial appendage and you did AFib ablation. And again, this one's 100,000 patients in this study. How do you do this? We're not going to get into all the specifics of this, but what we've been working on with my partner, Jim Cox, who invented the Cox-Maze procedure, and he's here with me now at Northwestern, is how do we make this practical for surgeons to approach these patients? We want to make it so that it is pretty simple to do, but very effective and very safe. So this was just published recently, and this is our practical approach. And for the purposes of this audience, I'll just break it down into this is the group of patients where the left atrium is open, mitral valve type surgery. That's the most common patient with atrial fib before surgery and the most common of the operations. This group of patients where you don't open the left atrium, coronary bypass, aortic valve replacement, an aneurysm type operation, a little bit more complex, needs a different approach in some of those patients. So just briefly, just to show a little bit of surgical video, this is what it looks like. This is a clip that is available now commercially to close the left atrial appendage. So at the time that the surgeon stops the heart to do mitral valve surgery and opens it, gives cardioplegia. And then I have my OR crew time me from the time that I elevated the heart, exposed this, my assistant and I put the clip on and then dropped the heart back into the chest was 84 seconds to do this. It's routinely less than 2 minutes to do this. It's very safe. It reduces stroke by 33% over time. This is something that's really important to do. The new clips that are out, there are more of them coming out, 98% effective at completely eliminating any communication between the left atrium and the appendage. And then in addition, as a benefit, it becomes electrically isolated, the left atrial appendage. There's some necrosis of the base of the left atrial appendage because the clip is compressing the blood supply. And so it also becomes electrically isolated, which is important for the second part, which is the ablation. So here is a mitral valve operation. This is the older way we used to do this, the so-called cut and sew Cox-Maze 3 procedure with many suture lines, pretty complex. Not very many of us did this. Here's the new way to do this, to use cryoprobes, 3 minutes of cryoablation, and you are going to create this box lesion, just as the electrophysiologist attempt to do. We also get a lesion across the left atrial appendage, which is occluded and electrically isolated. We get one to the mitral isthmus by bending the probe a little bit, and then another one briefly on the coronary sinus, which is quick and easy to do and clearly visible. This is only 8 minutes of ablation. It doesn't add very much to doing this type of operation. We published these results about 2 years ago, and we are looking at since 2013, when we started to publish the late survival improvement done at 100% of the patients with mitral valve disease undergoing surgery who had atrial fib had concomitant ablation. So it's not a lot of exceptions. We just do it if they're paroxysmal atrial fib, if they've had atrial fib for 10 years, any patient. It's quick and it is safe. It added just over 10 minutes of cross-clamp time, 13 minutes of bypass time. There was no increase in renal dysfunction or pacemakers, less than 1% risk for a pacemaker with just a mitral valve operation and a maze. The survival wasn't just improved to the same as patients undergoing mitral valve surgery. It was improved to the level of a age and sex match CDC population. So you return those patients to their expected survival. Freedom from stroke at 5 years, over 98%, quite good for a group of patients that have a significant CHADS2 VAS score. And then the freedom from atrial fib for the 3-minute freeze lesions at 1 year, 92%, 89% at 2, 82% at 3 years with extended monitoring like a Zio patch. So the results have actually been quite good with this. This is practical and easily adopted. There's some new technology that is outcoming. So for instance, this is a bipolar radiofrequency clamp. If you're doing a coronary bypass or an aortic valve replacement, something where you don't have to open the left atrium, then you can put this clamp around, and this is going to create the box lesion of all four pulmonary veins. If you then also put a clip on the left atrial appendage and connect it, then you've done the box lesion in the left atrial appendage. The only part you haven't done is the mitral annulus and the coronary sinus. And so this is new technology. It's being adopted rapidly. The results aren't all published yet, but so far it looks encouraging with this. So in that summary, I would just say, if you have a patient with AFib and they need open heart surgery, there's a lot of new information that is coming out in cardiac surgery, a lot of new studies that have been published. It's worth a conversation with your surgeon about closing the left atrial appendage and then doing concomitant ablation. Sometimes within groups, not all the surgeons know the different techniques, but within a group, there's usually one or two surgeons that are actually quite comfortable with doing this, and you should seek that surgeon out and refer specifically for that surgeon. Thank you very much. I hope that this was helpful.